Welcome to Pediatric Case Review. Today's lecture covers Cushing syndrome comprehensively. We will explore clinical presentation, diagnostic approaches, treatment strategies, and complications. This intermediate-level discussion is designed for residents, nurses, and healthcare professionals. By the end, you will confidently recognize and manage Cushing syndrome in clinical practice. A 10-year-old girl presents with 15-kilogram weight gain over 8 months, primarily central distribution. Her mother reports facial rounding, easy bruising, and poor growth despite weight gain. Height percentile dropped from 50th to 25th. What is the most likely diagnosis? Option A, hypothyroidism. Option B, simple obesity. Option C, Cushing syndrome. Option D, growth hormone deficiency. The correct answer is C, Cushing syndrome. The combination of central weight gain with growth deceleration is pathognomonic for pediatric Cushing syndrome. This is the most important distinguishing feature from simple obesity, which typically causes tall stature, not short stature. The easy bruising and facial rounding further support hypercortisolism. A 14-year-old boy presents with progressive facial fullness over 6 months. His mother shows photographs revealing moon face, facial plethora, and acne. There is no fever or allergic history. These facial changes are most consistent with which condition? Option A, allergic reaction. Option B, nephrotic syndrome. Option C, hypercortisolism. Option D, hypothyroidism. The correct answer is C, hypercortisolism. Moon facies results from abnormal fat redistribution to the face. Facial plethora occurs due to skin thinning and increased visibility of blood vessels. The acne reflects androgen excess that commonly accompanies cortisol elevation. Together, these create the characteristic Cushingoid appearance, distinguishing it from other causes of facial swelling. A 12-year-old girl presents with purple stretch marks on her abdomen and thighs, appearing over 4 months. The marks are wider than 1 centimeter. She also experiences easy bruising with minimal trauma. What is the medical term for these characteristic stretch marks? Option A, striae distensi. Option B, striae rubra. Option C, striae violacea. Option D, striae gravidarum. The correct answer is C, striae violacea. These are pathognomonic purple striae characteristic of Cushing syndrome. Excess cortisol inhibits collagen synthesis, causing skin weakness. When rapid weight gain occurs, the weakened dermis tears, creating wide purple marks typically greater than 1 centimeter. Their presence strongly suggests hypercortisolism rather than simple obesity or adolescent growth. A 9-year-old boy complains of difficulty climbing stairs and rising from sitting position. His mother notes he uses his arms to push himself up from chairs. There is no pain and reflexes are normal. This presentation most suggests which condition? Option A, muscular dystrophy. Option B, proximal myopathy from hypercortisolism. Option C, peripheral neuropathy. Option D, juvenile arthritis. The correct answer is B, proximal myopathy from hypercortisolism. Excess cortisol causes muscle protein breakdown, predominantly affecting proximal muscle groups, including hip and shoulder girdles. The chair sign, where patients use arms to rise from sitting, is characteristic. This painless weakness with preserved reflexes distinguishes it from inflammatory myopathies and helps diagnose Cushing syndrome. An 11-year-old child presents with newly diagnosed hypertension. Blood pressure is 145/95 millimeters of mercury. The child is obese with central fat distribution. Echocardiogram shows left ventricular hypertrophy. Which hormone excess best explains this hypertension? Option A, aldosterone only. Option B, cortisol with mineralocorticoid effect. Option C, catecholamines. Option D, growth hormone. The correct answer is B, cortisol with mineralocorticoid effect. Excess cortisol causes hypertension through multiple mechanisms. It activates mineralocorticoid receptors causing sodium and water retention. Cortisol also increases vascular sensitivity to vasopressors and reduces nitric oxide production. These combined effects explain why hypertension occurs in approximately 80% of pediatric Cushing cases and may cause significant cardiovascular complications. Physical examination reveals a prominent fat pad at the posterior neck base, commonly called buffalo hump, and increased supraclavicular fat pads bilaterally. The patient also has thin extremities. This fat distribution pattern is most characteristic of which condition? Option A, metabolic syndrome. Option B, lipodystrophy. Option C, Cushing syndrome. Option D, familial obesity. The correct answer is C, Cushing syndrome. Hypercortisolism causes characteristic fat redistribution with central obesity, including buffalo hump and supraclavicular fat pads, combined with thin extremities. This occurs because cortisol differentially affects adipocytes in various body regions. The combination of truncal obesity with extremity wasting creates the distinctive Cushing-Goid body habitus that aids clinical diagnosis. A 13-year-old girl presents with excessive facial hair, acne, and irregular menstruation. Physical examination shows terminal hair on upper lip and chin. No clitoromegaly is noted. This presentation most suggests excess of which hormone group? Option A, estrogen. Option B, progesterone. Option C, androgens. Option D, growth hormone. The correct answer is C, androgens. In Cushing syndrome, especially from adrenal tumors, excess adrenal androgens cause hirsutism, acne, and menstrual irregularities. Mild features are common, but severe virilization with clitoromegaly suggests malignant adrenal tumor. Androgen excess is more pronounced in adrenal causes compared to pituitary-dependent Cushing disease. This finding aids in determining the underlying etiology. A 10-year-old child with Cushing syndrome undergoes bone density scanning showing a Z-score of -2.8 in lumbar spine. The patient reports a recent forearm fracture from minor fall. What is the primary mechanism of bone loss? Option A, decreased calcium absorption. Option B, increased osteoclast activity. Option C, decreased osteoblast function. Option D, increased parathyroid hormone. The correct answer is C, decreased osteoblast function. Cortisol primarily inhibits osteoblast activity, reducing bone formation. Additionally, cortisol decreases intestinal calcium absorption and increases urinary calcium excretion. These combined effects cause severe osteoporosis in children with Cushing syndrome. Fractures from minimal trauma are common. Bone health assessment and protection are critical components of management. A 15-year-old with Cushing syndrome presents with polyuria and polydipsia. Random glucose is 240 milligrams per deciliter. Hemoglobin A1C is 8.2%. There is no diabetic ketoacidosis. What is the mechanism of this hyperglycemia? Option A, decreased insulin secretion only. Option B, increased hepatic glucose production and insulin resistance. Option C, increased glucose absorption. Option D, decreased renal glucose excretion. The correct answer is B, increased hepatic glucose production and insulin resistance. Excess cortisol stimulates hepatic gluconeogenesis and causes peripheral insulin resistance in muscle and adipose tissue. This dual effect creates hyperglycemia. Approximately 20 to 40% of pediatric Cushing patients develop steroid diabetes. Unlike type 1 diabetes, ketoacidosis is rare. Management requires treating the underlying hypercortisolism. An 8-year-old is diagnosed with hypercortisolism. Adrenocorticotropic hormone level is 85 picograms per milliliter, which is elevated. Magnetic resonance imaging shows a 6 mm pituitary adenoma. This represents which type of Cushing? Option A, Cushing disease. Option B, adrenal adenoma. Option C, ectopic adrenocorticotropic hormone syndrome. Option D, iatrogenic Cushing. The correct answer is A, Cushing disease. This term specifically refers to pituitary adenoma, secreting excess adrenocorticotropic hormone, the most common cause in children accounting for 60 to 70% of cases. Cushing syndrome is the broader term encompassing hypercortisolism from any cause including adrenal tumors, ectopic hormone production, or exogenous steroids. Correct terminology aids clinical communication. You are explaining Cushing pathophysiology to medical students. Normally, corticotropin-releasing hormone stimulates adrenocorticotropic hormone production, which stimulates cortisol secretion. Cortisol then provides negative feedback to the hypothalamus and pituitary. In Cushing disease, what is lost? Option A, corticotropin-releasing hormone production. Option B, adrenocorticotropic hormone production. Option C, normal negative feedback. Option D, cortisol production. The correct answer is C, normal negative feedback. In Cushing disease, the pituitary adenoma secretes adrenocorticotropic hormone autonomously, partially resistant to cortisol's negative feedback. This causes unregulated cortisol production. While some feedback remains, enabling high-dose dexamethasone suppression testing, normal physiologic control is lost. Understanding this pathophysiology explains why cortisol levels remain elevated despite the body's attempt at regulation. A 12-year-old presents with clinical features suggesting Cushing syndrome. You want to screen for hypercortisolism before pursuing specialized testing. What is the best initial test? Option A, random serum cortisol. Option B, late-night salivary cortisol. Option C, magnetic resonance imaging of pituitary. Option D, adrenocorticotropic hormone stimulation test. Choose the most appropriate screening test. The correct answer is B, late-night salivary cortisol. This is an excellent screening test because it is non-invasive and detects loss of normal circadian rhythm. Cortisol should be lowest at midnight. In Cushing syndrome, nighttime cortisol remains elevated. Two elevated measurements strongly suggest hypercortisolism. This test has high sensitivity and specificity while being practical for pediatric patients. A patient receives 1 mg dexamethasone at 11 p.m. The next morning at 8 a.m., serum cortisol is measured at 18 micrograms per deciliter. Normal is less than 1.8 micrograms per deciliter. This result indicates which of the following? Option A, normal suppression, excludes Cushing. Option B, lack of suppression, suggests Cushing. Option C, test was performed incorrectly. Option D, patient has adrenal insufficiency. The correct answer is B, lack of suppression suggesting Cushing syndrome. Normally, dexamethasone suppresses pituitary adrenocorticotropic hormone secretion, lowering cortisol below 1.8 micrograms per deciliter. In Cushing syndrome, autonomous cortisol production prevents adequate suppression. However, this screening test has false positives, so confirmation with 24-hour urinary free cortisol or additional testing is essential before proceeding to imaging. A 24-hour urine collection shows urinary free cortisol of 280 micrograms per day. Normal is less than 50 micrograms per day. A repeated test shows 310 micrograms per day. These results do what? Option A, exclude Cushing syndrome. Option B, confirm hypercortisolism. Option C, suggest adrenal insufficiency. Option D, are normal for stressed patients. The correct answer is B, confirm hypercortisolism. Urinary free cortisol greater than 4 times the upper limit of normal strongly confirms Cushing syndrome. Repeating the test eliminates collection errors and transient elevations. With biochemical confirmation established, the next diagnostic step is measuring plasma adrenocorticotropic hormone to determine whether the source is pituitary-dependent, adrenal, or ectopic. This guides subsequent imaging and treatment. A patient has confirmed hypercortisolism. Plasma adrenocorticotropic hormone measured at 8 a.m. is 5 picograms per milliliter. Normal range is 10 to 60 picograms per milliliter. Repeated measurement confirms the low level. This indicates the source is which of the following? Option A, pituitary adenoma. Option B, adrenal tumor. Option C, ectopic adrenocorticotropic hormone. Option D, iatrogenic from steroids. The correct answer is B, adrenal tumor. Low adrenocorticotropic hormone with high cortisol indicates adrenocorticotropic hormone-independent Cushing syndrome from autonomous adrenal cortisol production. The high cortisol suppresses normal pituitary adrenocorticotropic hormone secretion. This finding directs imaging to the adrenal glands rather than pituitary. Adrenal computed tomography or magnetic resonance imaging will identify adenoma, carcinoma, or bilateral hyperplasia as the cause. A patient has elevated adrenocorticotropic hormone at 100 picograms per milliliter and confirmed hypercortisolism. After receiving high-dose dexamethasone at 8 milligrams, cortisol decreases by 60% from baseline. This pattern suggests which diagnosis? Option A, adrenal adenoma. Option B, pituitary adenoma, also known as Cushing disease. Option C, ectopic adrenocorticotropic hormone syndrome. Option D, primary adrenal hyperplasia. The correct answer is B, pituitary adenoma or Cushing disease. Pituitary adenomas retain partial responsiveness to negative feedback. High-dose dexamethasone suppresses cortisol by greater than 50% in Cushing disease. Ectopic adrenocorticotropic hormone tumors typically show no suppression. This test helps differentiate between pituitary and ectopic sources when adrenocorticotropic hormone is elevated, guiding appropriate imaging studies for localization. A 14-year-old has biochemically confirmed Cushing disease. Pituitary magnetic resonance imaging shows a 4 mm hypoenhancing lesion in the right anterior pituitary. The stalk is midline. What is the best next step? Option A, repeat magnetic resonance imaging in 6 months. Option B, proceed with transsphenoidal surgery. Option C, bilateral inferior petrosal sinus sampling. Option D, radiation therapy. The correct answer is C, bilateral inferior petrosal sinus sampling. While the magnetic resonance imaging shows a lesion, approximately 10% of normal individuals have pituitary incidentallomas. Petrosal sinus sampling directly measures adrenocorticotropic hormone from pituitary venous drainage and compares it to peripheral levels. A central to peripheral ratio greater than 2 confirms pituitary source and may help lateralize the adenoma, improving surgical success rates. Computed tomography of the abdomen shows a 5 centimeter right adrenal mass with irregular borders, areas of necrosis, and local invasion. The left adrenal gland is normal. The patient is 16 years old. These findings are most concerning for which diagnosis? Option A, benign adrenal adenoma. Option B, adrenal hyperplasia. Option C, adrenal carcinoma. Option D, pheochromocytoma. The correct answer is C, adrenal carcinoma. Features suggesting malignancy include large size greater than 4 centimeters, irregular borders, heterogeneous enhancement, necrosis, local invasion, and calcification. Adrenocortical carcinoma is rare but aggressive in children. It often presents with combined hypercortisolism and virilization. Treatment requires complete surgical resection with wide margins. Despite aggressive treatment, prognosis remains guarded with significant recurrence risk. An 11-year-old patient is awaiting pituitary surgery in 4 weeks. The child has severe hypertension at 160 over 100 millimeters of mercury and glucose intolerance. You need to control hypercortisolism preoperatively. Which medication best lowers cortisol acutely? Option A, metirapone. Option B, spironolactone. Option C, propranolol. Option D, metformin. The correct answer is A, metirapone. This medication inhibits 11-beta-hydroxylase, the enzyme converting 11-deoxycortisol to cortisol. It rapidly lowers cortisol levels within days. Metirapone helps control hypertension, hyperglycemia, and other complications while awaiting definitive surgery. Ketoconazole is an alternative that inhibits multiple steroidogenic enzymes. Both medications require monitoring for adrenal insufficiency and electrolyte disturbances during treatment. A 12-year-old with confirmed pituitary microadenoma undergoes transphenoidal surgery. On postoperative day 1, the cortisol level is 2 micrograms per deciliter. This finding indicates which of the following? Option A, surgical failure with tumor remaining. Option B, successful tumor removal. Option C, adrenal crisis developing. Option D, laboratory error. The correct answer is B, successful tumor removal. Postoperative hypocortisolism is the best predictor of surgical cure. Chronic hypercortisolism suppresses normal corticotroph cells and contralateral adrenal function. After tumor removal, patients develop temporary adrenal insufficiency requiring glucocorticoid replacement for months to years until the hypothalamic pituitary adrenal axis recovers. This postoperative hypocortisolism confirms complete adenoma resection and excellent prognosis. A post-surgical Cushing patient is on hydrocortisone replacement. The child develops fever of 38.5 degrees Celsius and vomiting, cannot keep oral medications down, and appears lethargic. What is appropriate management? Option A, continue same oral dose. Option B, stop hydrocortisone until eating. Option C, triple oral dose if able, or give intravenous hydrocortisone. Option D, give antipyretics only. The correct answer is C, triple oral dose if able, or give intravenous hydrocortisone. During illness, stress increases cortisol requirements. Patients with adrenal insufficiency cannot mount appropriate response and risk adrenal crisis. Stress dosing involves doubling to tripling maintenance doses. If vomiting prevents oral intake, parenteral hydrocortisone is essential. This prevents life-threatening adrenal crisis with hypotension, hypoglycemia, and shock. A 13-year-old has refractory Cushing disease. After 2 failed transphenoidal surgeries, persistent hypercortisolism continues. Radiation therapy is planned, but slow response is expected. What surgical option rapidly cures the hypercortisolism? Option A, third transphenoidal surgery. Option B, bilateral adrenalectomy. Option C, unilateral adrenalectomy. Option D, pituitary total hypophysectomy. The correct answer is B, bilateral adrenalectomy. This immediately cures hypercortisolism when other treatments fail. However, it creates permanent adrenal insufficiency requiring lifelong glucocorticoid and mineralocorticoid replacement. Additionally, 15 to 30% develop Nelson syndrome, where the pituitary tumor grows unrestrained without cortisol feedback, causing hyperpigmentation and potential mass effects. Close monitoring with serial magnetic resonance imaging is essential postoperatively. A 10-year-old with persistent Cushing disease after surgery receives pituitary radiation therapy. The parents ask about the expected timeline for cortisol normalization. What is the typical time to achieve biochemical remission? Option A, 2 to 4 weeks. Option B, 2 to 3 months. Option C, 6 to 18 months. Option D, 3 to 5 years. The correct answer is C, 6 to 18 months. Radiation therapy works slowly, with cortisol levels gradually declining over this period. Success rate is 50 to 60% for long-term remission. During this interval, medical therapy with metirapone or ketoconazole controls hypercortisolism. Long-term risks include hypopituitarism affecting growth hormone, thyroid, and gonadal axis, requiring lifelong endocrine monitoring and replacement. A 15-year-old has a 2-year history of untreated Cushing syndrome. Echocardiogram shows left ventricular hypertrophy, ejection fraction of 50%, and mild mitral regurgitation. Blood pressure is 150/95. What is the primary cardiovascular risk? Option A, arrhythmias. Option B, left heart failure and coronary disease. Option C, pulmonary hypertension. Option D, pericardial effusion. The correct answer is B, left heart failure and coronary disease. Chronic hypercortisolism causes hypertension, left ventricular hypertrophy, accelerated atherosclerosis, and endothelial dysfunction. These lead to heart failure and premature coronary disease, the leading causes of mortality in Cushing syndrome. Cardiovascular complications may persist despite successful treatment. Aggressive blood pressure management and cardiovascular risk reduction are essential components of comprehensive care. A 9-year-old with Cushing syndrome develops fever, productive cough, and a right lower lobe infiltrate on chest X-ray. There is concern for opportunistic infection, which infection risk is increased in hypercortisolism. Option A, viral infections only. Option B, fungal and opportunistic infections. Option C, no increased infection risk. Option D, parasitic infections only.